Good morning, everyone. We'll get started in just a minute. Okay, hi everyone. Welcome. Happy Friday. It's good to see so many of you here today. It's about 10:01, so we're going to go ahead and get started. My name is Jeanette Vong. I'm a health program specialist here at the California Department of Aging. I'm part of the Aging and Disability Resource Connection, or ADRC branch. I'm an Asian American female with long black hair, and I have on a light pink top today. So just some logistics. I'll be running through the presentation this morning and providing you all with an introduction to Medicaid Administrative Claiming, or MAC, for ADRCs. I believe you are all muted right now, but after the presentation, we'll go ahead and unmute everybody so that we can have an open and informal forum. We also have Wilson Tam here. He is our chief at the ADRC branch. So he and I will be able to field any questions or comments after the presentation. And we also have Tessa here who's supporting us behind the scenes. So thank you, Tessa. There's also closed captioning available for you to access by clicking on the closed captioning feature on the bottom of the screen. Feel free to also use the chat throughout if anything pops in your head. The presentation is being recorded and will also be available on our website to access in the near future. Okay, so moving on to our next slide, let's take a look at what we have on our agenda for today. Okay, so our overarching goal today is really to just try and provide you all with a very basic understanding of what Medicaid Administrative Claiming is. If you already know what it is, that's great. But if you're not quite sure what it is, our hope is to have you come out of here with at least a general concept of how MAC works and how it can specifically be applied to ADRCs. So in order to do that, we do want to spend a little bit of time first going over some Medi-Cal basics, because I think having that foundational understanding of what Medi-Cal is and how it's specifically funded will really help you to better understand MAC. So we'll do just a little bit of Medi-Cal 101. We'll then provide you with an overview on the key concepts of MAC. We'll also walk you through the major pieces that need to be put in place in order to fully build out this process for ADRCs. That includes going over our projected timeline for implementation. We'll also talk about the value in pursuing MAC and why we're even here today. And then we'll touch on next steps and where we go from here as far as moving forward. Okay, so Medi-Cal basics. What is Medi-Cal? Who does it serve? And how is it even funded? That's what we're going to cover on the next few slides. Okay, so Medi-Cal is just California's Medicaid program. It's essentially free or low-cost health coverage for children and adults with limited income and resources. By health coverage, we're talking about a number of covered healthcare benefits, such as outpatient services, emergency services, hospitalization, prescription drugs, labs, therapy, preventive services, pediatric services, mental health services, substance use disorder services, plus dental, vision, long-term care. It's also important to understand that Medi-Cal is a joint program funded through a So who does Medi-Cal serve? Just to give you some perspective first, there are almost about 40 million people in California. I think we're at about 39.5 million right now. So Medi-Cal serves 13.3 million Californians, which is about a third of the state's population. So that's 5.4 million children, which is actually more than half the children in the state. 6.7 million adults ages 21 to 64, and 1.2 million adults 65 and older. Okay, so how is Medi-Cal financed? Well, remember, Medi-Cal is a joint partnership between the federal and state government. So financing for Medi-Cal is a shared responsibility between the feds and the state. So the federal government actually picks up quite a hefty portion of the bill. The federal share of Medicaid spending nationally is about 65%, which is close to what it is in California as well. So here on this slide, you see a pie chart of the breakdown of Medi-Cal spending for California in fiscal year 2021. Expenditures were well over 100 billion. And of that, about 2/3 was from federal funds. The remaining 1/3 was from non-federal funds, which includes state general funds, local matching funds, provider fees, and health plan taxes. Okay, so how do we determine how much the federal share actually is? So basically, any state that operates its Medicaid program within federal guidelines is entitled to receive federal reimbursement for a share of its total program costs. So states will incur costs by making payments to healthcare providers, managed care plans, or even performing administrative tasks like making eligibility determinations, enrolling and monitoring providers, and paying claims. So all of that costs the state money. So the way that states receive matching federal dollars is by submitting Medicaid expenditure reports to the feds. So when we talk about Medicaid financing, and specifically the federal share, you're always going to hear two terms, Fmap and FFP. So FFP stands for Federal Financial Participation. It's just the actual federal government's share, so it's a dollar amount. And then Fmap stands for Federal Medical Assistance Percentage. It's the actual rate used to calculate the federal share, so it's a percentage. But both of these terms are referring to the same concept. So whenever you hear FFP or Fmap, we're always talking about that federal share or federal match or federal contribution or federal reimbursement. It's all the same idea. So let me walk you through some very simple examples to show you how it works. So say for every dollar the state puts in to fund its Medicaid program, if the Fmap is 50%, then the feds would match 50 cents for every state dollar spent. If the Fmap is 60%, then the federal reimbursement would instead be 60 cents. And if the Fmap is 70 cents, then the FFP or federal share would be 70 cents. Not every state has the same Fmap. The Fmap is actually based on a formula that provides a higher reimbursement to states with a lower per capita income compared to the national average. So in California, the Fmap happens to be 50% for most things. However, the feds will reimburse at a higher percentage for certain populations or activities. Okay, so we know how the federal share is calculated. Let's talk a little bit about the state's responsibility. Well, every state has what's called a Medicaid state plan. And what that is it's a comprehensive written agreement between the feds and the state. And by feds, we mean the Centers for Medicare and Medicaid Services, or CMS. So what this state plan does is it describes the nature and scope of the state's Medicaid program, including all of the covered benefits and who's covered. It also provides assurances that the state's going to follow the federal rules in order to claim matching federal funds. In every state too, there's also what's called a designated state Medicaid agency, and that agency is responsible for administering and overseeing the state plan. There can only be one state Medicaid agency in each state. So in California, it happens to be the Department of Healthcare Services, or DHCS. So that's why when it comes to anything that is Medi-Cal related, whether it's a new benefit or a new program, you're always going to see that close collaboration with DHCS. And later on, when we get into Medicaid Administrative Claiming, you'll see that even though CDA may oversee the ADRC program, when it comes to building out this MAC process for ADRCs, because it involves getting that federal reimbursement, it needs to go through DHCS and then to CMS for approval. So here on this slide, we have two figures shaking hands, as well as the logos from both CMS and DHCS, just to signify that federal-state partnership. Okay, so Medicaid claiming now. Medicaid claiming is the same thing as FFP. It's just a very broad term that refers to getting that federal reimbursement for work that states do to support its Medicaid programs. So Title 19 of the Social Security Act is the actual authority that allows states to get federal reimbursement for not only providing medical assistance or actual healthcare benefits to people, but for administrative activities as well. So remember, healthcare benefits are those Medi-Cal services I mentioned earlier, like physician services or hospital services, even long-term care, or services covered under a Medi-Cal waiver. So what the rest of this presentation is going to focus on is not getting federal reimbursement for those actual healthcare benefits, but rather that administration piece. So that's what we mean by Medicaid administrative claiming. It's getting that FFP or federal reimbursement for administrative activities only. Okay, so now when it comes to ADRCs, the role that ADRCs play in assisting people with navigating through that maze of long-term services and supports actually includes many administrative activities that are eligible for Medicaid claiming. We'll get into some of those examples later, but for now, just know that the acronym MAC is being used interchangeably for both Medicaid administrative claiming as well as Medi-Cal administrative claiming. And then we just want to reinforce again that we're talking strictly about administrative functions only and not the provision of actual healthcare benefits. Okay, so we're gonna transition into the MAC overview portion now. All of the information before was just prerequisite background knowledge to kind of orient you on how Medi-Cal is financed, specifically the federal portion and how FFP works. You also understand what the state plan is and DHCS's role as a single state Medicaid agency. And you also understand the distinction between general Medicaid claiming versus Medicaid administrative claiming. So what we're going to cover next are the key concepts of MAC. So you get an overall understanding of how that works. So first of all, Medicaid administrative claiming is not anything new, even though the MAC process for ADRCs will be new. Just know that DHCS has implemented MAC for a few other programs already. So for counties, mental health plans, schools, tribes, and some other programs, they all have processes in place to claim FFP for conducting administrative activities already. So why do we want to build out this MAC process for ADRCs specifically, and also why now? Well, one of the reasons is because there's an actual state law that's directing us to do so. So as we all know, there has been a lot of focus lately on statewide ADRC expansion, We know the demographics in California are rapidly changing. Our state leaders are really starting to recognize how ADRC partnerships are optimally positioned to help people access LTSS in the home and community. Statewide expansion is in the governor's master plan for aging. So thinking of ways to help sustain that no wrong door system is especially critical now. So in 2019, there was a Senate Bill 453, that added a section into state law. And what Section 9123 of the Welfare and Institutions Code did was it directed DHCS to work with the Department of Aging to determine if MAC can be used to help fund the no wrong door system. So under letter A, it lists out examples of no wrong door activities that may be eligible for MAC, including outreach, person-centered options counseling, training, program planning, and quality improvement. And then under letter B, it gives DHCS the authority to take necessary action to receive funding through MAC if it's determined that those activities are claimable. So that was the state authority. This is the federal authority. Now, this is probably one of the most important slides because it literally is the only place in actual federal statute where you're going to see administrative activities even remotely defined. Now, it's not exactly in layman's terms, not to me anyway, it's kind of in that legalese. So let's break it down together. So we have Title 19 of the Social Security Act. So basically under Section 1903 A7, it's essentially saying that for any state that has an approved plan, federal reimbursement is available at a rate of 50% for expenditures made by the state that are found by the secretary for the proper and efficient administration of the state plan. I know it's a bit of a mouthful and you're probably thinking, well, that doesn't clearly spell out what administrative activities are. And you're right, it doesn't. It's a very roundabout way of even referencing administrative activities. And unfortunately, you're not going to see administrative activities clearly defined, not in actual federal statute anyway. Okay, so we bolded and underlined the key takeaways for you. So the first thing that you need to do is have a state plan that has been approved by the feds. That's why I wanted you to understand what the state plan is. It's just that agreement between DHCS and CMS that outlines the scope of services under the Medi-Cal program. 50%, just a fancy way of saying that the rate of reimbursement is 50%. So that's our Fmap. Quarter, that's going to be the frequency at which we submit claims and seek reimbursement from the feds, so on a quarterly basis. And now the trickiest part, how do we know what activities or state expenditures actually qualify for this 50% reimbursement? Well, according to the statute, only activities found necessary by the secretary for the proper and efficient administration of the state plan. So it's pretty vague and it's also pretty broad. Now, the Secretary of Health and Human Services is the final arbiter who decides what activities meet this threshold. But unless we have a direct beeline to the secretary, as the state, we still have the flexibility to come up with a proposal that outlines ADRC activities that we believe fall under this broad definition. But the good news is that CMS does provide us with a little bit more guidance than the Social Security Act does. So CMS guidance says that federal matching funds under Medicaid are available for costs incurred by the state for administrative activities that either, one, directly support efforts to identify and enroll potential eligibles into Medicaid, or two, directly support the provision of medical services covered under the state Medicaid plan. Okay, so for number one, at least, it gives us something to work with. That one's more straightforward. We know that our ADRCs assist with identifying people who may be eligible for Medi-Cal and help to facilitate that enrollment process. But for number two, it still seems pretty broad to me. Exactly what administrative activities would support the provision of medical services covered under the state plan? So good news again, this time the Administration for Community Living, or ACL, does narrow this down further for us. And this time the guidance is actually more specific to ADRCs. So ACL identifies the following ADRC activities that may be eligible for MAC, such as Medi-Cal outreach, or providing information on Medi-Cal programs and services to consumers, person-centered options counseling, helping people understand and weigh out their options, including discussions on Medi-Cal programs and even Medi-Cal spend down, facilitating Medi-Cal eligibility, like we mentioned before, participating in training on Medi-Cal programs and services, and then program planning and quality improvement activities that specifically have to do with Medi-Cal. Now, keep in mind that these are just examples. It's not to say that this is an all-inclusive list or that we even need to claim for all of these things either. It's just guidance. But again, as the state, we still have that flexibility to submit a proposal that identifies administrative activities that we believe meet the criteria under that broad definition for MAC. Okay, so we have a general understanding of the types of ADRC activities that are claimable under MAC. Now we're going to get into how this translates into actual reimbursement. So in order to calculate FFP, there are two basic concepts you need to understand. The first one is how to calculate the maximum potential for reimbursement. So what we would do first is identify all staff who actually perform activities eligible for MAC. It can be staff from the AAA or the ILC or even extended partners. Well, for each one of those staff, we would individually calculate how much we can seek reimbursement for. So let's say we have Jean Smith, who spends maybe only half her time performing activities eligible for MAC. We would need to figure out how much it costs to fund Jean Smith's total position for a given quarter. Because remember, we're submitting claims on a quarterly basis. That would include her salary, fringe benefits, perhaps some overhead or indirect costs. We would take that total cost and multiply it by the percentage of time she actually spends performing MAC activities. And then, since we know that the feds will reimburse for 50%, we would divide it by 2. So that's all this first formula is. It's calculating that maximum potential for reimbursement for a staff member who performs MAC activities. So you just take how much it costs to fund their entire position, multiply it by the percentage of time they spend on performing MAC tasks, and then take half of it. Now, just because we know how much the maximum potential for reimbursement is, doesn't mean that we'll be able to claim that entire amount. It really depends on how much of Jean Smith's position is actually funded by local funds that are even eligible for match. So remember, the feds are only going to match half of what the state puts in using its own dollars. FFP can't be claimed for activities that are already reimbursed by another source, such as a Medi-Cal service, other federal dollars, or a third-party payer. So say you're using all federal dollars, like CARES Act funds, to fund Jean Smith's position. It doesn't matter if Jean Smith spends 50% or even 100% of her time on Medi-Cal related tasks. The feds are not going to match a federal dollar with another federal dollar. It's just not the way FFP works. Now, if Jane Smith's position is funded by ADRC infrastructure grants, then that's a different story. Since those funds are coming out of the state's own pocket, those funds can be used for match. So the second concept I want you to understand is that you also need to take into consideration how a position is funded, specifically how much is funded with state or local matching funds. So in the second formula here, it just walks you through how to calculate how much local matching funds are available. And in order to do that, you just take the total cost of that staff member and multiply it by the percentage of that position that is funded by local dollars. So if your matching funds available are equal to or more than that maximum potential for reimbursement, you can claim that maximum FFP. But if your matching funds available are less than the maximum potential for reimbursement, you won't be able to claim that maximum amount. It doesn't mean you can't claim anything. It just means you can only claim up to what you have available for match. Okay, so I know that's a lot. If you're not a formulas person, I get it. And if I completely lost you, don't worry about it. For the next 2 slides, I'm going to try and walk you through a very simple example to show you how this works. Okay, so this is just an example of how to use that first formula to calculate the maximum potential for FFP. Now, for the sake of keeping the numbers nice and round and easy to work with, let's just say that it cost $100,000 to fund Jane Smith's position for a quarter. That includes her salary, her fringe benefits, and any other overhead costs. Let's also say that during that quarter, she's keeping track of how much time she spends on activities that are eligible for MAC, like providing information on Medi-Cal programs, facilitating Medi-Cal eligibility, educating people on their options when it comes to Medi-Cal. After keeping track of that for a full quarter, let's say that she spends 20% of her time on MAC tasks. Well, to calculate the maximum FFP that can be claimed for Jane Smith, we would just take $100,000 and multiply it by 20%, which is $20,000. And then since the federal rate for reimbursement is 50%, we would just divide that in half, which would be $10,000. So $10,000 is the maximum amount that could be claimed for Jane Smith for that given quarter. So pretty straightforward. It's really just a matter of keeping track of how much time is being spent on MAC activities, and then also knowing how much it costs to fund her total position. Okay, so we know how to calculate the maximum FFP. Calculating the actual FFP that can be claimed is where it gets a little tricky, because this is where we have to take into consideration how Jane Smith's position is actually funded. Okay, so using that exact same example on the previous slide, let's play with some scenarios just to see how the actual FFP can fluctuate based on how Jane Smith's position is funded. So again, cost $100,000 to fund Jane Smith's position for a quarter. She spends 20% of her time on MAC activities, and we already determined that the maximum FFP that can be claimed is $10,000. Okay, so we have 4 different scenarios here as examples. So for the first one, let's say that 100% of her position is funded with CARES Act funds, and 0% is from local funds. Well, 0% of 100,000 is 0. So that means there would be 0 local dollars available for the feds to match. So it wouldn't even matter how much time she spent on MAC activities. There's just nothing to match since her position isn't funded with any local dollars. For the second example, let's say that this time 50% of her position is funded with local dollars. So let's say 50% CARES Act and 50% ADRC infrastructure grants. So 50% of 100,000 would be 50,000. But remember how that maximum FFP is only 10,000? That means that the most you can claim in this scenario is still only 10,000. So it's great that you have more than enough matching funds available, but it doesn't change the fact that you can still only claim up to the maximum FFP. So let's look at the third example. This time, let's say Jane Smith's position is funded primarily with federal dollars, and this time only 5% with local funds. So 5% of 100,000 is 5,000. So even though the maximum FFP is 10,000, we can't claim that full 10,000 because we don't have 10,000 local matching funds available. We only have 5,000. So in this case, we can only claim 5,000. And let's look at this last example. Let's say 10% of Jane Smith's salary is funded by local dollars. 10% of 100,000 is 10,000. So with this scenario, based on the 20% of time Jane Smith spends on MAC activities, having 10% of her position funded through local funds just so happens to allow us to claim exactly that maximum FFP. Now, if you're still totally lost, don't worry too much about it. What I do want you to take away from all of this is understanding that the actual amount that can be claimed not only depends on how much time staff spend performing MAC tasks, but also how their positions are funded, because that's what's going to determine how much matching funds are available. So this was really more to show your fiscal team how they can be a little strategic to maximize the amount that can be claimed. You really want to make sure that for those staff who are really spending the most time doing MAC activities, their positions are funded with sufficient permissible local funds that are available for match. So again, if I lost you on the last 3 slides, I do apologize. It's not need to know information at this point in time. But this slide you do want to pay attention to because it's a flowchart diagram that summarizes the entire MAC process once fully implemented. Okay, so starting in the upper right-hand corner, where it says ADRC partners, we're going to work our way backwards in a C pattern here. So this is where the ADRC partners would first identify the local staff who actually perform those Medi-Cal administrative activities. Those staff would participate in quarterly time studies to identify how much time they spend on MAC activities. ADRC partners would figure out how much it costs to fund each of those positions for that given quarter, and they would determine the portion of costs funded by local dollars. All of that information would enable the ADRC partner to calculate not only the maximum potential for reimbursement for each staff, but also the actual FFP that can be claimed. And then the ADRC partnership would aggregate all that data from their core and or extended partners and provide those cost reports to CDA. Now, CDA would validate everything, make sure the time studies were being completed, calculate the reimbursement, verify that there are sufficient matching dollars. CDA would then submit the invoice to DHCS. Then DHCS, as the single state Medicaid agency, would request reimbursement from CMS. CMS would review the claim. CMS would release the funds to DHCS, who in turn would release the funds to CDA, who in turn would release the funds to the respective ADRC partnerships. And this cycle would repeat on a quarterly basis. So that's a very high-level overview of both the flow of the claiming submission process as well as the flow of funding. I do want to note that there has to be an interagency agreement between DHCS and CDA, as well as memorandum of understandings between CDA and each of the ADRC partnerships. And that's because as the single state Medicaid agency, DHCS is the only entity that can request FFP from CMS. So the contractual agreements really need to define the relationship between DHCS and the no wrong door system entities, as well as document the scope of activities to be performed on behalf of the Medi-Cal program. Okay, so we have a general understanding of what the MAC process looks like. But now, how do we implement this for our ADRCs in California? Well, the overall concept of MAC seems simple enough. There are a lot of details and logistics that need to be worked out. So to kind of break this project down into more manageable parts, what we did was we identified and chunked out the major pieces that need to be put in place in order to fully implement this. So the approach that we're going to take is to tackle and address questions as they arise and as we dive into each phase of the project, rather than trying to contemplate every little detail from the onset. So just keep in mind that you probably will have more questions than we have answers for at this point in time. But as we work our way through each phase of the project, that's when we'll be sure to engage and seek stakeholder input once we start making those decisions. So what I want to do now is kind of walk you through those major pieces that need to be put in place in order to fully build out this process. So the first thing we need to do is identify ADRC activities that are eligible for MAC. So in the yellow bubble to the right, remember, we already have those examples from ACL, Medi-Cal outreach, person-centered options planning or counseling, facilitating Medi-Cal eligibility. So we don't need to completely start from scratch and reinvent the wheel, but we do also want to make sure that the activities make sense to the workers who will be coding their time and appear similar to what CMS has seen and approved in the past. Now, I mentioned before that the concept of MAC is not new to California, so it's not like we don't have other DHCS examples to draw on. However, activities that say schools or counties or even tribes perform are not necessarily the same as ADRCs. The ADRC's role in helping to support the provision of services under the state plan is very unique and distinct, specifically when it comes to outreaching that Medi-Cal spend down population. So we can't just lift those activities and place them into our proposal. We also know there are other states that have successfully implemented MAC for ADRCs. Again, great examples to look at, but we need to keep in mind that what may work for one state may not work for California. California, I think, is the only state where we define in state statute that both the AAA and ILC are core partners of the ADRC. So when we develop our list of administrative activities, we really need to make sure that they're representative of tasks that the AAA and the ILC and possibly extended partners perform. So all of this is to say that yes, there is guidance out there to help us define which administrative activities can be claimable, but you've also seen how broad that actual language is in the Social Security Act. So at the same time, we just want to recognize that we do have flexibility to really tailor our MAC process to fit the no wrong door system in California. Okay, but once we do identify those tasks, we just need to identify the local staff who actually perform them. And then we need to develop corresponding codes so that staff can classify how they spend their time so that we can distinguish Medi-Cal related tasks from non-Medi-Cal related tasks. Because remember, ADRCs serve all populations and payers. Once we develop those codes, we'll want to conduct what's called a code clarity pilot to actually test them. So staff would actually practice coding their time just to make sure the code descriptions are clear and accurately reflect the activities being performed. And then feedback from that pilot would help us refine and finalize those codes. After we have our codes, the next step would be to develop our time study methodology. So in a time study, each staff who performs MAC activities would use those codes to document how they spend their time. The ultimate goal here is to be able to extract out how much time is spent performing MAC activities. So it's just a matter of coming up with a methodology to figure out what that process looks like. The one thing we do know is that time studies need to take place on a quarterly basis. But aside from that, there are a lot of different ways to go about doing this. So some states do what's called a random moment time survey, where actual software is used to prompt staff on certain days of the quarter to tell them today is the day you're going to start coding your time. And then based on the sample of data that's collected, that's applied to the entire quarter. Some states have staff record 100% of their time for each day of the quarter. So they're using a daily log or timesheet to code time in 15-minute increments. And then some states do an alternative method and might document time for only a certain number of days or weeks during a quarter. So whatever methodology we decide, we just need to make sure that our proposal is statistically valid and accurately extracts the amount of time spent on MAC tasks. At the same time, we want to make sure the process is not overly burdensome on the ADRCs. So again, once we get to this phase, we'll be sure to seek input from the ADRCs to make sure that everything is feasible. In looking at the bottom of the slide, you'll see that we popped in that formula again on how to calculate the maximum potential for reimbursement. So remember, in order to do this, we need to know two things. We need to know the total cost for the position, and we need to know how much time is spent on MAC tasks. So the results of the time study, it's what's going to help us populate that percentage of time spent on MAC tasks. Once we have our time study methodology, the next step is to work on our claims submission process. So part of this has to do with figuring out that total operational cost for each staff member who participates in the time study. Now, the total cost would include not only salaries, wages, and fringe benefits, but can also include overhead and indirect costs too. But once we know that total cost, we have that second missing piece of the formula and can calculate the maximum potential for reimbursement for each staff. Now, remember, the maximum potential for reimbursement is one thing, but the actual amount that can be claimed depends on the amount of local matching funds available. So we also need to take a look at how each position is funded. So basically, to develop this entire claims submission process, we need to develop quarterly spreadsheets and invoices that can be piloted by the local ADRC partners. The spreadsheets need to document the cost for each staff, isolate salaries and wages from overhead costs, document the amount of local matching funds are available for each position, calculate the actual amount that can be claimed, and aggregate all of that data. So again, probably a lot more questions than we have answers for at this time, but we envision hammering out all of those details once we get to this stage. This slide just shows those examples of reimbursable costs that can be factored into the total operational cost for each staff member. So like salaries and wages, fringe benefits, indirect costs, travel, vehicle costs, training, phone, postage, printing, etc. Okay, so at this point, let's say we develop the codes, we have our time study, we have our claim submission process all worked out. Well, the next thing we would need to do is build out our monitoring and oversight processes. Because we're seeking that federal reimbursement, CMS is going to want to see We have systems in place to make sure that we are accurately claiming FFP and continually monitoring this process on an ongoing basis. So on this slide here, we have just some examples of oversight processes that need to be developed on both the state and local side. So for the state, CDA would need processes in place to oversee the claiming infrastructure, conduct training, gather and review cost spreadsheets, calculate the quarterly reimbursements, disperse payments to the local sites, and develop audit processes to conduct fiscal reviews and time study sampling. And then on the local side, our ADRCs would similarly need to develop protocols to ensure that appropriate staff participate in time studies. Staff are maintaining sufficient documentation to support time spent on MAC tasks. ADRCs are accurately reporting and tracking permissible sources of funds used as match, and basically just ensuring the accurate completion of fiscal spreadsheets. So all of these are just examples of things that we need to think through. In addition to having monitoring processes in place, we also need to develop actual contractual agreements. We briefly discussed this earlier, but since DHCS is the single state Medicaid agency, there has to be an interagency agreement, memorandum of understanding, or some other contractual agreement in effect before DHCS can submit claims for federal reimbursement. And that would be true for any MAC activities conducted by any entity other than the state Medicaid agency. So these contractual agreements need to describe and define the relationship between DHCS and the No Wrong Door System entity. It also needs to document the scope of activities to be performed by the ADRCs on behalf of the Medicaid program. So that's why we have to have an agreement in place, not only between DHCS and CDA, but also between CDA and each one of the ADRC partnerships participating in MAC. And then finally, our final step would be to compile and gather everything that we've developed, all of our policies, all of our processes, and submit our proposal to CMS for review. So that would include a description of all of the activity codes, our time study methodology, our cost allocation plan and claiming submission process, the contractual agreements between DHCS and CDA and the ADRCs, any oversight and monitoring protocols, training materials, invoice templates. So all of that information would need to be compiled into a submission packet. Even though CDA will be taking the lead on all of these items, we will be collaborating with our DHCS colleagues every step of the way. So ultimately, DHCS will be the one submitting the proposal to CMS for review and approval. Okay, so this slide here shows you our projected timeline. So for each one of those steps we just went over, we've laid them out across a timeline so that you can see how all of the pieces fit together. Please keep in mind that this is just an estimate. As we tackle each phase, we'll continue to look at examples from other states and consult with ACL and DHCS for guidance. But like I mentioned before, there are a lot of unknowns out there. So we've tried to build in that cushion room, anticipating that a lot of research still needs to be done to try and resolve those questions. So just know that this timeline remains flexible, but we still wanted to give you an idea of the sequence of activities. So let's go ahead and walk through the timeline together. So right now, let's look at the pink. We're in 2021. We're doing this MAC overview presentation. We're halfway through the year. So the rest of the year, we want to focus on developing those activity codes and conducting the code clarity pilot to really have those codes tested and finalized by the end of the year. Moving on to 2022, the yellow, Here we want to focus on developing our time study methodology as well as our claims submission process. We know that there are a lot of details that need to be figured out here. We want to do a mock time study for a full quarter and actually go through all of the steps and complete all of the spreadsheets as if we were actually calculating FFP and seeking reimbursement. And then, of course, we want to take time to analyze those results to get a ballpark idea of how much we can claim. Moving on to 2023, or the green, we'll be using the results from those time studies to inform our November and May estimates. Those tasks are more for CDA and DHCS to worry about, though. But in 2023, we'll also be working on developing all of those state and local monitoring processes. We'll also be drafting the local and state MOUs. And then knowing that our final deliverable is that submission packet to CMS, throughout each major phase, we'll be concurrently working on compiling materials and drafting both the local guidance manual for our ADRCs as well as our federal submission packet. So we're targeting submitting that packet to CMS by the end of 2023. And then moving on to 2024, or the blue, assuming that CMS takes no more than 6 months to approve the proposal, we'd like to formally begin claiming reimbursement no later than July of 2024. So while we're waiting CMS approval, we would continue completing quarterly time studies and calculating FFP as if we were actually claiming. Okay, so we're almost there, you guys. Just a few more slides, I promise. So our final section covers the value in pursuing MAC. So aside from state law, which directs us to explore MAC, why else do we want to build out this process for ADRCs? So let's talk a little bit about the landscape in spending for long-term services and supports, and not just California, but nationwide. So Medicaid continues to be the primary source of coverage for LTSS spending. In 2018, Medicaid financed over half of these services. So when it comes to financing long-term care, California, as well as the nation, really face an unprecedented crisis. Traditionally, the responsibility has always fallen on unpaid family caregivers. But when paid services are needed, that's when most Californians are not financially prepared. People who are able to utilize their own resources are unable to do so on an ongoing basis. So oftentimes people are forced to decrease their standard of living, leave long-term care needs unmet, and or spend down their savings to qualify for Medi-Cal. So the interaction between ADRCs and Medi-Cal is a critical one. ADRCs are well positioned to streamline Medi-Cal enrollment and eligibility, divert people into non-Medi-Cal services, and potentially delay or prevent Medi-Cal spend down. So it makes a lot of sense to implement MAC for ADRCs because ADRCs help people prepare for and access Medi-Cal. So what's the value in MAC? So MAC is just one avenue for helping to sustain and support a no wrong door system. It's an ongoing source of funding. There is no cap on federal or state spending. And once approved by CMS, funding will continue so long as we continue doing those quarterly time studies and submitting claims to CMS. MAC also strengthens the case for state and local funding and reinforces that local agencies are a core infrastructure supporting the Medicaid program. It also demonstrates that the ADRC network promotes self-sufficiency, independence, and community living. And ultimately, staff are already doing the work, so why not get reimbursed for it? Now, this isn't to downplay the amount of work that's going to have to go into building out the MAC process, not to mention overseeing it. There's no doubt there will be new administrative duties like participating in time studies, maintaining an audit trail that documents a client's link to Medi-Cal, validating funding streams, calculating invoices. But once those processes are put in place, we really think the initial investment will be worth the return. CARES Act money won't be here forever. And even with an ongoing source of funding through the infrastructure grants, as we expand ADRCs statewide, that funding will be spread out across more and more ADRCs. So having that sustainable source of funding really becomes important. So let's look at where MAC is being implemented nationwide. So as of May 2021, we have 16 states that are currently already claiming. We have 11 states, including California, that are in the planning stages. And then just one state, Iowa, that is awaiting CMS approval. So that's more than half of our nation. Now, the claiming amounts for states range from about 500,000 to 2 million per year. But this really can vary considerably based on a number of things: the size of the state, the number of ADRCs participating, the types of activities being claimed, the number of staff participating in the time studies. So in California, with our AAAs and ILCs as core partners, there's a lot of potential for reimbursement. So as we build out this MAC process, we would love to see all of our ADRC partnerships not only participate in the actual claiming, but in the development process as well. Okay, so next steps, where do we go from here? Well, according to our timeline, the next thing we need to focus on is identifying those administrative activities that are claimable and then coming up with our codes. I think having the right codes from the onset is very important because it sets the foundation for the scope of activities that can be claimed, which will directly impact the amount of reimbursement. Like I mentioned before, we do have guidance from ACL as well as examples from other states and DHCS. But at the same time, that definition in the Social Security Act is still very broad. So even though we have a general sense of what you all do, we don't have that boots on the ground knowledge. So what I kind of want to do is just sit down with some of you and just pick your brains a little bit. I want to know everything and anything that you do when it comes to Medi-Cal. I want to know what types of activities that are provided, the frequency of those activities. So that's the direction we want to take over the next couple of months, just really getting that local input to develop those codes. Okay, I know that was a lot. Thank you so much for your patience and your attention. It looks like we have plenty of time for any questions or comments or thoughts. So if Tessa, if you can please go ahead and unmute everyone, that would be great. For those of you on the phone, I think you may still need to press *9 to raise your hand first and then *6 to unmute yourself. But let's go ahead and have an open discussion, informal forum.
Hi, good morning. This is Miley Haynes. I'm a manager with the Office on Aging. I believe I posted a question in the chat and I believe you answered it. It was for the FFP claiming. That was for per quarter. For the max 10,000, correct?
Correct, on a quarterly basis.
Thank you. Okay, thank you.
So this really is an open discussion. Again, if you guys have any questions, if you like me to go back on any slides to re-explain anything, I'd be happy to. But also any comments, thoughts are welcome also.
Just a comment, Jeanette. This is Miley again from Office on Aging.
Okay.
Just as a follow-up to your closing remark about sitting and meeting with some of the agencies, boots on the ground, and getting an idea of what some of those administrative activities could be in terms of identifying those tasks and time study codes that would be linked to those activities. I would offer to volunteer when you're ready to have some meetings set up, myself and maybe one or two of my team members from Riverside County Office on Aging.
Okay, great. Thank you, Miley. And
I'll put in my contact in the chat.
And
Thanks.
we'll definitely follow up with the group to all of the stakeholders to let you all know about next steps. And we'll outreach everybody too and give everyone an opportunity to provide input and participate. So thank you for that.
So Jeanette, this is Victoria Jump in Ventura. Excellent presentation. You made this really clear and understandable. I do have a question about, so the intent now is to spread the MAC funding to potential extended partners as well. Is that what I'm hearing? So it's not just the core partners, it's anybody that's part of our network potentially?
I think that's definitely up for discussion. So when it comes to that phase, I think it's definitely up for discussion. I don't see anywhere right now in the research that I've done clear guidance on that. To me, it makes sense. You know, the ADRC is a partnership of various partners. So this proposal is to authorize that claiming for the ADRC partnership. So I'd say at this time, it makes sense to me that potentially extended partners, as well as the core partners, anyone who does those tasks and is willing to do those time studies and put in all the work to claim, I think it makes sense.
Okay, thank you. And I would also add that you can sign up our ADRC to have the discussion about the codes.
Okay, thank you, Victoria. And thank you, Wilson. I see you're fielding, I think, some of the chat questions, so I appreciate that.
Of course, you're welcome. And one of the chat or the comments that have been, this is Wilson, by the way. One of the chat items that or comments that haven't been answered yet was from Carly. She asked, could staff providing MAC ADRC activities, but they're funded without any ADRC dollars, be eligible for MAC reimbursement? And correct me if I'm wrong, Jeanette, it's as long as you have non-federal local dollars that have not already been used for federal match, even if they're not ADRC related dollars, it could be, you know, like a local city or county, you know, funding that could be used as match.
Yes, yep.
Even though and that would be, you know, hopefully in addition, any city or county dollars would be in addition to the state general fund dollars of ADRC infrastructure grants.
Yeah, that sounds right, Wilson. And when we do get to that claiming submission process, we probably can iron out and provide very clear guidance on what permissible sources of funding can be. So we'll provide that guidance later down the line. Okay, so it doesn't look like we have any more comments or questions. Again, feel free to chime in if you do have any feedback.
There is one more question in the chat.
which question was that, Tessa or Wilson?
It's the last one from Brit. Can MAC be seen as an incentive to potential partners to participate in ADRC support activities? Are these dollars that otherwise wouldn't be available to partner organizations? Think this was just answered.
Okay, thanks, Britt. Yeah, I think however you guys expand your ADRC partnerships, whether using incentives or not, it's kind of up to you guys. But yes, like we mentioned before, I think those extended partners who potentially do those administrative activities would be eligible to claim MAC. So I kind of envision, and this may or may not be how it plays out in the end, but I envision each of those partners, core partners, extended partners, you know, they have to identify their own staff who perform those activities. They complete the time studies. Ultimately, that has to get funneled through perhaps the fiscal entity for the ADRC partnership, so that when it comes to CDA, we just get, you know, the invoice from the ADRC partnership. But things can change as we continue researching and figuring out these things. So that's what my understanding is at this point in time. Thanks, Brad. Okay, so last call. I know that was long, so thank you again for your attention. I appreciate it. Wilson, any last words?
No, nothing from me. I think the gist of it is that we're hoping that this, you know, orientation kind of gives you a broad overview of what MAC is, you know, like Jeanette mentioned earlier, providing you the prerequisites and also just kind of the basics of what is to come. I think what's even more important to this orientation is what's going to really be followed up in next steps, like Jeanette mentioned earlier, is just having that stakeholder input, because, you know, we can come up with different processes and such that works for at the state level, but it may not, you know, work for our ADRC partners at the local level. So your partnership and input into this process will be very valuable. So we look forward to that conversation.
Okay. Well, thank you all again for joining. I hope you enjoy the rest of your Friday and have a great weekend. And we will talk to you all another time.
Thank you, everyone.